Good morning, everybody. Welcome to Pediatric Grand Rounds. Today we have three excellent speakers today, and I'm going to introduce Dr. Sue Apcon, who is a professor in the Department of Rehab Medicine and the director of the Rehab Medicine program here at Seattle Children's, to do the rest of the introductions. Welcome, everybody.
Thanks, Suzanne. I'm going to jump right in. First to thank Suzanne and the hospital for giving us an opportunity to speak today. In 1999, I had an experience that really impacted me both professionally as well as personally. As I was transitioning between being a resident and attending, it's about a 6-month period, I was in our rehab clinic where we diagnosed 3 infant girls with spinal muscular atrophy type 1. For those of you who don't know what SMA type 1 is, we'll be talking a lot about it, but briefly, it's a progressive neuromuscular condition, leads to profound muscle weakness, and ultimately death by about a year of age. What I learned at that time was that SMA is a horrible disease. I learned that these 3 particular families were unable to care for their infants in their home setting, and so we opted to bring them in onto our inpatient rehab unit where we cared for them for several months until each of them died at about a year of age, each about a month apart. I learned that SMA is a disease of the motor neurons. Again, it leads to significant muscle weakness, difficulty with swallowing, difficulty with breathing, and again, ultimately, death. At that time, I decided that I was committing myself and rallying the team around me to provide the highest level of supportive care that we could. There was no cure for SMA at that time, and so supportive care was really what we had. Now in 2018, while we still don't have a cure, we have some novel treatments that we're going to be spending time talking about today. Along with the novel treatments, however, come several challenges, many ethical dilemmas that personally I've sort of struggled with, and then as a team we've struggled with. So I'm going to be joined today by 2 colleagues, Dr. Mandy Striegel, an assistant professor in the Department of Pediatrics in the Division of Pulmonary Medicine, and Dr. Ben Wilfond, professor of pediatrics, also in the Division of Pulmonary Medicine, but the division chief for bioethics. And together we're going to share the story of kids with spinal muscular atrophy and then the challenges that we all face when caring for them, especially in the setting of these novel treatments. And we're hoping to leave lots of time today for you in the audience to also participate in this discussion. We'd love to hear from you about your thoughts. I do have one disclosure. I have provided some consultation to Biogen, who does manufacture one of the drugs that we'll be talking about, and Dr. Wilfond and Dr. Striegel have no disclosures. So it's important to have a little bit of a background. So I talked about the 3 infant girls that we diagnosed and we cared for, but what I didn't say is that actually not only infants, but children and even adults have spinal muscular atrophy. There are 4 types, although we're going to talk about the 3 childhood types today. Children with spinal muscular atrophy have a homozygous deletion of the SMN1 gene. The SMN1 gene produces a protein, the survivor motor neuron protein, which is necessary for the viability of the motor neurons. And without them, it leads to that profound muscle weakness that I described. The carrier rate is high, only second to cystic fibrosis, 1 in 40 to 1 in 90, depending on the race and ethnicity of the child. 1 in 10,000 live births are affected by spinal muscular atrophy. It's the #1 genetic cause of infant mortality. People with SMA, I said, don't have the survivor motor neuron 1 gene, but we all have a backup copy. It's referred to, not very creatively, as the SMN2 gene. And the SMN2 gene, while it produces some of the protein necessary for the viability of the motor neurons, it's only about 10% of the SMN protein that we need. The only difference between the SMN1 gene and the SMN2 gene is a single nucleotide. I could C to T change, and that results in the exclusion of exon 7 in this gene. And so without exon 7, you produce a very shortened protein, and it's not viable. This background, I think, is important because it also gives context to the treatments that I'm going to be talking about. So spinal muscular atrophy type 1 is the most common type of SMA. 60 to 70% of people born with spinal muscular atrophy have type 1. These are alert, interactive infants. Remember, this is a disease of the motor neurons. It doesn't affect the brain. So these are alert, interactive, smart infants, kids, and adults. Infants present before 6 months of age with hypotonia and weakness, and most describe them as incredibly floppy. So if you think about a Raggedy Ann doll with no muscle tone at all, this is an infant with spinal muscular atrophy type 1. They have difficulty with swallowing, severe pulmonary complications with difficulty clearing their airway and ventilating. And ultimately, as I said, it's a progressive course with death in a large cohort study at about 10.5 months of age. Children with type 2 SMA generally present after 6 months of age, generally between 6 and 18 months of age. So we refer to the infants with type 1 as non-sitters, and kids with type 2 we refer to as sitters. So they achieve the milestone of sitting, but don't really progress beyond that. Some might stand with support, maybe take a few steps with support, but they do not walk independently. Their course is a little bit more variable. It is progressive, but much less so and in a much slower rate than the infants. If you look at children with SMA type 2 over a 1-year period, their motor skills are actually fairly stable. If you look at them over 2 to 3 years, however, that's when you start seeing the motor skill decline. And many think that it's actually not a progressive muscle weakness, but it's the fact that they can't keep up, their motor skills can't keep up with the growth and development of their body. So weak muscles on a bigger child makes it more difficult to progress in your motor skills. Life expectancy for children with type 2 SMA is into adulthood in the majority of people. And that's with a tremendous amount of supportive care that we'll be talking about. And then the third type of childhood onset SMA is SMA type 3, and these are kids who walk. They're diagnosed generally after 18 months of age, and they're diagnosed because they walk funny. They too are weak, they're hypotonic, and their walking pattern is a little bit wide-based, they're a little bit lordotic, and then they have the waddling pattern of someone with proximal muscle weakness. Their course is also variable, with some losing the ability to walk very early, and others walking into adulthood. Their life expectancy is generally considered normal. So in 1999, when I first was involved with the diagnosis of infants and the care of infants and children with spinal muscular atrophy, what we had was supportive care. We continue to have supportive care, and really it is the standard of care, even in 2018. The supportive care we have now has really evolved a lot, and so the care we're able to provide now has led to some improvements in life expectancy. So a real focus on nutrition, assuring especially the infants are getting adequate calories and hydration, so supplemental NG feeds or G-tube feeds, modifying their diets. The pulmonary care has changed tremendously, and you'll hear Dr. Striegel talk a little bit more about that. The use of non-invasive ventilation, cough assist machines, that wasn't, in 1999, that didn't exist. We used to makeshift some positive pressure ventilators to try to help the infants, but we weren't particularly successful. Orthopedic care has changed as well. So kids with spinal muscular atrophy type 2 have truncal weakness as well as a weakness in their limbs, and that leads to progressive scoliosis. And we're talking about 6-year-olds who have 60 and 80-degree curves. They're significant. With the use of growing constructs, so growing rods, vector systems, and now the magic rods, our orthopedic colleagues are able to treat kids younger. We used to have to wait until they were teenagers, until their spinal growth was sort of at its maximum, and now we're able to implant these growing rods in 5, 6, 7-year-olds, so we're maintaining an upright posture for much longer periods of time. And then as a rehab provider, looking at function, right? Trying to maximize a child's abilities in the setting of significant weakness. So referring kids to our therapy colleagues here at the hospital, as well as in the community. The use of adaptive equipment. This power wheelchair allows a child to be independently mobile in the community and in the home and the school setting. And as an entire SMA team, we really focus on ensuring that kids and families are well integrated into their community. Kids in school, families doing what families like to do. And so these are some slides that families sent me when they heard that I was giving this grand rounds. The picture on the left is a young woman with SMA type 1, and she was outfitted with some really sophisticated switches. And these switches are connected to her gaming system. And in the second slide that the mom sent me in this series, she showed me the score, and this kid was like 3 out of 10 of all the kids that were playing that game at that time. It was pretty incredible. Use of adaptive equipment to get kids on the beaches of Washington State and in the hills as well with ATVs. Again, we want families to be families. The other piece that I'll say is when I talk about supportive care, we also want to provide care that families want. And we support families with the decisions that they make, especially in the setting of our infants with type 1 and our children with fragile type 2. And so the early initiation of palliative care and hospice has been instrumental in providing families the support that they need to provide the care that they feel is most appropriate for their kids and families. So I said in 2018, we finally have a treatment, not a cure. There are a number of clinical trials. I'm going to talk about one, and I'm going to talk about the first FDA-approved drug. So on December 23rd of 2016, the FDA approved the first drug to treat spinal muscular atrophy. The gene therapy trial was published in November of this past year, and actually there was a complement article, 2 articles, this one and then the article on Nusinersen treatment, which is the other one I'll talk about. But gene therapy is basically taking an AAV9 capsid or using it as a delivery system to put a self-complementary transgene. So that gene is able to replicate on its own. It's injected systemically, so by IV, into the child one time. That gene makes its way to the motor neurons and other cells, because other cells also produce SMN protein, and it produces the protein. So this trial was based at a nationwide children's hospital with Jerry Mendel as the principal investigator. They looked at 3 outcome measures: safety, event-free survival. And event-free survival was described as being alive or death, and then permanent ventilation for greater than 16 hours per day for greater than 2 weeks. So this 2-week period allowed for an infant to get sick with a viral illness, maybe need invasive or non-invasive ventilation for a period of 2 weeks, recover, and then come off it. So event-free survival, death, or permanent ventilation, and then motor function. The results, and there were 15 infants under 6 or 7 months of age that were included in this trial. They had type 1 SMA with 2 copies of that gene. So just briefly, I didn't mention, there's a genotype-phenotype correlation. In other words, the more copies of the SMN2 gene you have, the stronger you will be. So infants have 2 copies. Children with type 2 have 3 copies of that gene. And then people with type 3 have 4 or more copies of this gene. So the gene copy is relevant, again, when we think about treatment. So the results of this gene therapy trial, there were 2 treatment-related serious adverse events. There was a marked elevation in liver function enzymes. The treatment then changed, and so all children were then pre-treated around the time they had their gene therapy with prednisone, and that liver function enzymes decreased and normalized. The results showed that at 20 months, all infants treated were alive and without permanent ventilation. There was a younger cohort that started, and they were up to 30 months alive and without permanent ventilation. And then the other group was, I think, an average of 25 months out. All patients improved on the CHOP-INTEND. That's the measure of infant motor skills, specific for kids with spinal muscular atrophy, and all patients improved on that. And as a rehab provider, what was most significant was the unexpected milestones that these infants achieved. 11 of the 12 infants sat independently, something we don't see infants do with SMA type 1. 9 of the 12 rolled, 2 of the 12 crawled and even walked. That's something that has never been seen in the setting of SMA. The 2 infants who crawled and walked were also the youngest children that were treated in the cohort. And that's important when we think about the potential benefit that kids might receive. The second treatment is a drug called Nusinersen. I mentioned that on December 23rd of 2016, the FDA approved this drug for the treatment of all people with spinal muscular atrophy. So going back to the issue that I talked about at the gene level, so people with SMA are missing the SMN1 gene. They have this backup copy. The backup copy is missing exon 7. It's a splice site error. So this drug is an antisense oligonucleotide, which is a synthetic piece of DNA. It is injected via lumbar puncture. It binds to a flanking intron, so a piece of genetic code that is just adjacent to exon 7. It blocks something called the splice site silencer, thereby allowing exon 7 to be incorporated into the gene, so you can produce then a full-length SMN protein. The Nusinersen was injected again via lumbar puncture. It was actually a sham control. Now, you can't ethically do a lumbar puncture and not inject anything into an infant or even an older person. So the sham part was that the parents and the examiners were blinded. Each infant, whether they were treated or were a control, had a prick in their back. So the infants receiving the sham procedure had numbing cream on their back. They had a prick, a Band-Aid put on their back, and so the parents and the examiners were unable to tell the difference between those who received a lumbar puncture and those who didn't. Outcome measures were similar: safety, event-free survival. The only difference with this study was event-free survival was permanent ventilation beyond 3 weeks. So they allowed an infant to be sick for 3 weeks before they were considered a treatment failure. And then they too looked at motor milestone response. Now this study was actually stopped early. They had a predetermined interim analysis when 80 infants were enrolled. It was, I think, about 120 in the final study. So when 80 infants had been enrolled for 6 months, they analyzed the data, and they stopped the study because there was a significant difference in those receiving the treatment versus the controls in their motor milestone response. And you can see that those who were treated with Nusinersen, 51% of them were motor responders, as opposed to 0% in the control group. Event-free survival was 61% in the Nusinersen group compared to 32%, and 16% of the children with Nusinersen died compared to 39% who received were in the control arm. This is not a perfect drug. This is not a cure. This is a treatment. As I reflect back on the infants that I cared for as a resident, and really over the last almost 20 years now, the infants and children who I've cared for, and many of whom have died, I can't not wonder how this treatment, the gene therapy treatment, and then the treatments to come that are in clinical trial would have impacted them. We have been very lucky at Seattle Children's that this hospital supported our SMA team in providing this care, this treatment to kids. So I said on December 23rd, the FDA approved it, and you can bet that afternoon we started receiving emails and phone calls from parents expecting their kids to be treated the very next day. It was Christmas Eve, right? And they wanted this incredible gift. What they didn't realize, and frankly what our team didn't realize, was the tremendous amount of work that was going to go in to providing this treatment safely. And what we realized very quickly was some of the ethical challenges that we had at a personal level. I know I struggled, but also at an institutional level. And so we're going to transition now to some of those challenges. If you're interested in hearing a little bit more about them, or reading more about it, I have the reference here. JAMA Pediatrics published a really nice review on some of the challenges. At the top is cost, and we're going to talk about that. At $135,000 per vial, times 6 injections in the first year, you can bet that that raised a lot of eyebrows. There's a limitation of evidence. So here we are providing treatment to all kids from 0 to, we had 21-year-olds asking for this treatment, yet the evidence that was published was a small cohort of infants. Now, there have been other podium presentations not yet published of some of the other data that's coming out. We have participated in one of the trials here with Nina Natarajan as the principal investigator. And so there is additional evidence behind it, but the reality is we didn't have a lot. We did not have evidence that a 16-year-old with type 2 SMA who had very minimal movement and severe restrictive lung disease was going to have any benefit. How can you do an informed consent in that setting, right? How do I look at a family whose 5-month-old was just diagnosed and tell them that their child was going to benefit? We saw that infants still died with this treatment. And so I don't believe that informed consent is truly able to be accomplished. Treatment allocation. So we had about, at the time, 30 plus kids that wanted treatment. And it required a lot of people. So it required someone to do the injection. It required our insurance processing people to figure out if we had coverage for it. It required our ORs and our interventional radiology to be able to provide these services. Who gets the first injection, who gets second, and who goes third? Like, how do you queue up this group of kids and young adults to get this treatment? And how do you then realize, and this was, we certainly saw this in interventional radiology, how do you queue up the kids with SMA at the expense potentially of other kids who need those same services with other conditions? In this state, Seattle Children's is one of 2 institutions that actually provide this treatment. The other one is Madigan. There's a couple of kids through the military that they have treated, which is wonderful. But otherwise, we are the only ones. Our colleagues across the state have not been able to provide this treatment. Seattle Children's took a risk, and we have been able to deliver it. But that sets us up potentially for some challenges, potentially some financial impacts. Do the kids from the eastern side of the state all of a sudden get prioritized over the kids who we're caring for here at our own institution? And then finally, how do we be transparent about all of this? How do we let our families know what we're thinking? How do we let our families know that if an infant is diagnosed, even if your child who has type 2 or type 3 is queued in to start their injections, you know, they may get bumped because of an infant? How do we explain that to families? So fortunately, we have 2 experts who are going to help us to start thinking about some of that. And as Ben and Mandy and I sat down to talk about this presentation and what challenges would really we should really highlight, we started thinking a little bit about some of the older kids. Clearly, in the older kid cohort, the evidence is less clear. The risk is also higher because of the restrictive lung disease. The cost is always an issue. So is there sort of this intersect between potential for benefit, cost, risk, and how do we make that decision? And should there be a group that we may not offer this treatment to? So with that question, I'm going to invite Dr. Striegel up and share her thoughts.
Just use this microphone. Can you hear me okay? Okay, good. So as Sue mentioned, the process of formulating this talk was an opportunity for all of us to reflect. And so I took some time to stop and think about how did I feel a year ago when we were in the process of creating a plan to give Nusinersen to our patients. And I was very excited, as we all were, but I was also very anxious. And that anxiety was mainly borne forth by this huge tidal wave of hope that this drug was riding on for our families. And I think Sue pointed it out very nicely, that this is not a cure. This is a treatment. And so we needed to prepare ourselves for how we were going to counsel our families that their child may not have a very robust response, and what I was going to do with my management when that happened. And the two groups of patients that gave me the most anxiety were our smallest infants with SMA type 1. And they are clearly our most fragile from a respiratory perspective. And we thankfully had some data. We had some very positive data from the ENDEAR trial that Sue mentioned. But the thing that gave me pause is that if you sort of unpack that big positive outcome of reduction in death and use of permanent assisted ventilation, you see that the biggest impact was in death, which, mind you, is obviously a very positive outcome, but there were still a good proportion of children who needed respiratory support. And the thought was that we had some children who we were shifting from being so severe that they would never survive to now an intermediate level of severity that just needed a lot more care, which to me meant I had to get a lot better at my job pretty quickly. So there was that side of the coin. And then there's the older adolescents with SMA type 2 who are equally fragile from a respiratory perspective in some cases, but for slightly different reasons. And there was no data there. So when a family came to me and said, is this going to improve my child's lung function? Does this mean I can please not use my BiPAP tonight? Do I get to go through an illness without being hospitalized? I wasn't sure what I could tell them. As we went through the process of developing this plan of how to give this drug, that there was one obvious thing, right? Nusinersen is not an easy drug to give. You don't prescribe it and let your family take it at home. This required a procedure, an intrathecal injection, which I think we all, colleagues of mine in the emergency department in HEMONC know that a lumbar puncture itself doesn't carry a whole lot of risk, but when you're talking about serial lumbar punctures, and you're talking about a lumbar puncture in an infant who has restricted breathing and is dependent on their belly moving to get a good amount of air into their lungs, if you curl them up in a ball to give them a lumbar puncture, that can be particularly challenging. And for our older children and even adolescents who have spinal curves, there's the issue of just even accessing the intrathecal space, which can be very limited in terms of options. And so we definitely needed the help of our interventional radiologists. And knowing that that procedure itself may take a longer stretch of time, be more painful, be more anxiety provoking, we knew that we weren't going to go about this with the answer being no one was going to have anesthesia. So the biggest thing that I undertook in working with Elizabeth Martin and Sean Flack in anesthesia was talking about anesthesia risk for these kids. There is no such thing as a patient with SMA who has a low anesthesia risk for a variety of reasons. Many of them have a degree of airway obstruction, either from low tone, difficulty with managing secretions, and some of them with craniofacial differences that I'll show you. Most of them have an element of restrictive lung disease, sometimes incredibly severe. They all have difficulty with impairment of cough, so it's very challenging for them to move lower airway secretions and clear them effectively without help. And that actually starts very early on before restrictive lung disease is severe. And they all have issues with limited mobility. How do we position them? How can we help them to help themselves in situations where they're having a procedure or waking from anesthesia? I wanted to point out that the pathophysiology or the mechanism of restrictive lung disease is really different in babies as opposed to older children and adolescents. Infants with SMA have pretty preserved diaphragm function, but they have severely impaired abdominal muscle strength and intercostal muscle strength. So when they contract their diaphragms to breathe, pull down, their chest implodes in and their bellies go out. So it's a very inefficient mechanism of breathing. In most of the cases, these infants will need some form of positive pressure support during sleep, and certainly when they are ill. Luckily, our technology has improved drastically in the last several years so that we have BiPAP machines that can sense a small infant, masks that can fit a small infant, but we're still a little imperfect in what we do. In contrast, the older child and adolescent has a very stiff chest wall owing to contortion of the spine, impaired rib mobility, some contractures that can develop in those intercostal muscles themselves. So now you're dealing with restricted movement of the chest and sometimes very severely impaired lung volumes from sort of a fixed fixed implosion of the chest wall that can happen on one or both sides. These children and adolescents generally also need positive pressure during sleep to support their breathing as well. We follow all of our children who of school age at our clinic with lung function tests about every 6 months. And so I wanted to give you just a snapshot of what lung function looks like in our kids who are able to perform pulmonary function tests. So this shows you just one single best in the last year of all the kids that we follow, their age on the x-axis, and their forced vital capacity as a percentage of predicted for age and height on the y-axis. So you can see that we have a wide swath. We have some kids whose lung function is well below the cutoff for severe restriction at 30% down into the teens, and we have a few who are near normal. One difference between SMA as compared to other myopathies like Duchenne muscular dystrophy is that the decline is a little unpredictable in terms of at where you start. We have some children who, when they first start doing PFTs, are already in the 40s, and how fast you decline thereafter. Some will stay stable for a long time, then drop precipitously with an event such as an illness or their scoliosis surgery, and others will maintain for many months to years. I highlighted a few with the orange squares to show you that lung function doesn't always correlate with the child's daytime function or breathing during sleep in the same way that we would predict. These children with the orange squares are not actually using nighttime ventilation. They probably should be, but they're choosing not to, and at least by laboratory assessment, and in some cases by polysomnogram, they're good enough that they're not meeting criteria for chronic respiratory failure. So there's a lot of factors at play. Cough is huge. Cough is something we focus on a lot in our clinic visits and something we had to think about in the recovery process from anesthesia. Normally when we cough, we first take a deep breath in to near maximal lung capacity. We then close our glottis, contract our belly muscles to generate a high transthoracic and transabdominal pressure, and then expel mucus and air at flows that can be 500 to 1,000 liters per minute. Children with SMA can't breathe deeply. They can't contract their belly muscles forcefully, and so they can't cough hard enough to clear mucus effectively. Their cough peak flows, as we measure in our clinic, are generally somewhere between a half to a third of what we would expect for normal for their age. So we have to help, and this is, for anyone who hasn't ever seen it, a cough assist device. These are really critical to use for patients when they're sick. They're started as young as infancy, and all of our school-age kids and adolescents use them. What it is a positive and negative pressure device. So the child puts a mask on their face, and as they breathe in to start their cough, the air is pushed in at a set positive pressure, and then as they cough out, the air is actually pulled out at a set negative pressure, so you're enhancing what they're doing with their own cough. If they're really weak, then it's essentially doing the cough for them. But this requires some participation. It requires an airway that you can suction from afterwards, but is really critical for keeping them well during an illness, keeping them out of the hospital. One thing I had not thought about really until we embarked on this Nusinersen journey was airway. We just didn't have a reason for these kids to get repeated anesthesia. But it has been described in the literature that adolescents with SMA2 develop a very classic sort of long, slender, myopathic face, but also some mandibular regression, as you can see here in this teenager from the side profile. And they have very limited mouth opening, so their mandibular to maxillary opening, both on their own and with assistance, is about half of what it would be expected for normals. And the little guy up in the left corner there is one of our now toddlers who, with SMA1, who has been receiving Nusinersen for the longest stretch of time because of a clinical trial. And you can see that even he, at a young age, has some of this mandibular regression present and actually has a critical airway in terms of what can be viewed with a laryngoscope. So how does all of this kind of get put together to impact conversations that we have with families? So evaluation by a pulmonologist is part of the pre-Nusinersen or pre-Spinraza assessment, as is a trip to the anesthesia clinic to discuss options. We look at mouth opening, we look at jaw size, we talk about prior intubations, and we've actually, I can think of at least 2 adolescents where we have said, you do not have the option for anesthesia primarily because of their airway. We look at their breathing tests. We talk about whether they're using their BiPAP. We make sure that their lungs are as healthy as they can be, and we have had a couple of adolescents where we've been quite concerned about receiving anesthesia purely from a restrictive lung disease perspective, though it hasn't been an independent reason to say no. We talk about cough, and we make sure they have their cough assist machine with them when they come to these procedures. And I have to give a lot of gratitude to the respiratory therapy department here. They are doing something that's unprecedented in the hospital in terms of procedural support, and that is they're meeting these kids in the pre-op area and then again in the PACU to be available for airway clearance, suctioning, et cetera. So they've been really supportive in making sure we do this safely. And then we've had some creative positioning ideas from anesthesia, and we've also had the anesthesiologist supporting us, even with kids who are not getting anesthesia, to make sure that they have good airway patency and are safe for their case. So I'm just going to conclude with this last slide again, because I had an interesting conversation with Liz Martin from anesthesia last week when I was putting together this slide, and she said, you know, I really thought this was going to be more black and white. I really thought we were going to have like a hard line with one lung capacity where we just weren't going to do anesthesia. I really thought for everyone else that would get anesthesia, we would use the same plan every time. And I think when Sue and I have talked, we've looked back and said the same thing, that we thought there would be cases where we said, you're not a good anesthesia candidate, and the family would say, no. We thought there would be cases where we just couldn't access the intrathecal space, and we haven't really experienced that. So here again are all of our patients with SMA2 and their lung function, the BiPAP users and non-users in orange. All of these green circles indicate patients who have received inhaled anesthesia with a mask, so kind of spans the whole spectrum. And all of the red arrows indicate patients who have received IV anesthesia in the form of propofol, some independently and some in conjunction with an inhaled anesthetic, typically with an airway in place. So we're doing the work. We're actually doing it quite well, some in our most severe cases. And so now we're at a place, I feel, where we are challenged with trying to assess if the continued, arguably additive risk of each of these procedures that this child undertakes or adolescent undertakes is worth the perceived benefit that he or she may be having. So I'm going to stop here and hand off to Ben, and then we'll be back for questions.
Thank you, Sue and Mandy. I'll try to keep my comments brief because we want to make sure we have enough time for discussion. But I also think that Mandy's last comment is a really good segue into what I want to talk about, because just like she said, they were wishing for a rule of how to do the thing about safety. The way I got involved was that we actually had a bioethics consult from the hospital to think about the issues in providing this, particularly from a cost point of view. And again, they were looking for us to come up with a simple rule and figure this out. And the answer was, well, I'm not sure we can do that, but we can help you think through this as we go through our process. Now, there are a lot of things I could talk about. I could easily fill up an hour, which I'm not going to do. But what I chose to do is to talk about cost. And the purpose of talking about this is to suggest that this is also not straightforward and hard to figure out. And for me, this has been kind of an ongoing journey that I will continue to be involved with the team over time. And so what I want to do is, and so part of what bioethics does is many things, but some of it is trying to help us figure out what we should do. But in addition to that, it's trying to figure out what the questions are, what the concepts are, to have some definitional clarity. And so what I'm going to try to do is to do a little bit of each of those. But I first want to focus on the issue of definitional clarity. And so when we're thinking about the costs, I think we have to ask questions about, well, which costs? Whose cost? When we talk about costs, we have to really kind of be very clear about how we're talking about these. We can also think about how the cost of this drug compared to other drugs. As a way of analogy, we can think also about how the cost of the drugs compared to the cost of not providing the drugs for patients. All the services that Mandy described, as well as what Sue described, are themselves very costly. And so there's actually a trade-off between the cost for the drug versus the cost for supportive care without the drug. And finally, we can talk about the implications of this experience of thinking about these issues as it relates to other drugs that may be coming on the line that are as expensive or close to as expensive. So I want to talk about each of these issues in a few brief comments, and then we'll open this up. So let's talk more about the costs and define the costs. So I think it's important when we think about costs to be mindful that we're not only talking about the cost of the drug, but we're also talking about the time and resources. And I think you got a view of that from hearing from both Sue and Mandy, how much time and energy not only did they put into this, but a huge team put into thinking about this issue. Additionally, as was pointed out, there's issues of resources being deployed for this that otherwise would have gone to something else, and how do we think about our capacity issues? And so that really gets to this notion of opportunity cost. As we do this, what else are we potentially giving up? So these cost issues are very, are not simply a matter of dollars and cents, but can be quite complicated. And in other work, when I work with economists, it's pretty interesting how they think about these issues and try to look at all the range of costs that are involved. We also can think about whose cost. Are we talking about the cost to the family directly, which may vary depending upon what sort of coverage they do or don't have? The cost to the hospital. One of the things that is unique about Nusinersen is the fact that because it's provided only in an inpatient context, the mechanism we have for payment and support is different than those drugs that are provided as an outpatient or services provided as outpatient, such as home mechanical ventilation. And one of the challenges we have to think about there is thinking through what the obligations does the hospital have for providing this intervention, these services, compared to other services they may or may not provide. We also can think of this from the context of a health system. And here I'm using actually health system and insurance company, but I wouldn't use them interchangeably, but they're kind of similar concepts. Groups who are responsible for providing for the services to a large group of people. And as you know, more and more health systems are getting more complicated and trying to be more comprehensive as they do things. But again, those entities have to think about these issues also. And while we often like to disparage insurance companies as being part of the evil empire, the reality is that insurance companies are, for better or worse, are our mechanism for trying to actually have fair distribution of resources within a group of people. And so, as one of the things that really happened is that a lot of effort was put in, not only by our team, but not only by the team here, including Mark Del Beccaro and others, having conversations with the insurance companies, trying to sort through this in a very collaborative way. And finally, the government. By the government, I'm thinking about Medicaid and Medicare, who often are, and obviously not Medicare for our patients, but Medicaid, thinking about what sort of the government responsibility is, and how do they think about these issues. And what's been really fascinating is at least in my sense, of that some level of collaboration and interaction between everybody. So one of the things as I was preparing for this talk, I wanted to think about, well, how much does this drug cost compared to other drugs? And it was actually not very easy to figure this out, and I'm not sure I even got this right. But I want to share this slide to you to give you some idea. The stuff on the bottom that also talks about costs for U.S. patients, this is all from the CMS database, the Center for Medicaid Services. I think I forget what exactly it's called now. They actually have this wonderful database that talks about all of the things that they receive and how much they spend on different things. And what's interesting here, so I want you to look at the bottom for the first moment, you'll see that they talk about the annual cost per patient, but they also talk about the total cost for U.S. patients. So one of the things to think about for cost is not only how much per patient, but what's the cost of treating this condition. And you can see that actually the most expensive cost per patient that I could find for anything for adults are actually these drugs for pulmonary hypertension, among others. As well, also this drug, this is so, except that the population was very small. The drug for hepatitis C is perhaps the most costly drug collectively at close to $100,000 a person. Now, for pediatric drugs, in the last number of years, there have been a number of drugs that have been developed for rare diseases. Here, it's hard to get really good data, but what I was able to find were there's a number of biotech web-based journalist groups who sort of try to track this information. And from that, I was able to get some idea of the cost of a number of these drugs. And what you can see is that the treatment for SMA is within the range of these other drugs that are still quite expensive. Now again, for SMA, the cost is more for the first year, but it comes down afterwards. This only refers to the cost of the drug, not the cost of providing it. But you get some sense about that there are a number of these. And I think for me, part of the challenge is that the good news is that there will be more drugs. The bad news, they will also be very expensive. So how do we deal with this issue? I don't have any good answers, but what I want to do is at least make a comment about each of these quickly, and then we'll open this up for conversation. I think one of the things that we learned from Nusinersen that will be repeated over and over again, and has been repeated, for example, with Duchenne's muscular dystrophy, is the role of the patient perspective, the family perspective, both in the design of clinical trial, identifying endpoints, and in the approval process and approval decisions. What was most challenging, depending on how you look at it, was the fact that the decision was made to approve this drug for all patients, even though the study was done in infants with type 1. And so whereas in a circumstance where it was only approved in a smaller context, that would have given direction to hospitals, to insurance providers what to do. In this case, they said, it's up to you guys to figure this out. We're going to approve it for everybody. So that meant that providers, payers, have to themselves do the hard work of figuring out what the benefits are, what the costs are. Is this justified? Because normally the FDA does a more restrictive job of making those decisions. So one of the other issues, of course, is for pharmaceutical companies. I mentioned again that the cost of these drugs, the charge for these drugs is incredibly high. And I think one of the challenges we have in our current system is that we don't have a system for managing and engaging and controlling prices. And we've seen over the last number of years a number of companies really pushing this very hard to see how expensive things can be. And we have the example of the EpiPen, which I think is perhaps one of the most notable examples of this. I think this is an issue we haven't solved, and one that needs to be solved. We have to figure out some way of acknowledging the importance of pharmaceutical companies in developing new drugs, figuring out how to ensure that they are appropriately compensated, but have some way where this can actually be done within our health system in a way that makes it sustainable. I think payers have the obligation to think about how do they treat patients fairly, how do they make decisions across all their patients for this disease as well as others, and I think they've really struggled with this. And I think this is something that we have to continue to do more work on. One of the challenges that institutions chase, or our health systems face, is the issue of balancing the mission, and in this case, our mission to provide care regardless of cost, with sustainability. If we simply said we're going to pay for everybody instantaneously, the 40 patients, we're going to get this tomorrow, the cost of that would have been huge, but more importantly, it would have drained resources from other things, and at some point we have to think about, for this hospital to be sustainable, we have to think about how to sort of control that. In fact, the way this was done was really by working very closely with the insurance providers and trying to secure insurance coverage for these interventions. And finally, I think the issue for providers is, as Mandy and Sue described, is the importance of continually interact with the families, give them as much information as possible on an ongoing basis so they themselves are not feeling abandoned by the providers as these things come forward. So with that, I want to stop, and I guess I'm going to invite Sue and Mandy to come back up, and we'll take questions. And you can start by acknowledging your team, too.
Thank you very much. Before we open up to questions, I want to just acknowledge the incredible village that has been involved with providing treatment to this group of kids. So obviously the kids and the families, and for the families who were so gracious and sent me some of these wonderful pictures, including twin brothers who were receiving their sixth. They're showing us treatment just last month or two ago. We have an incredible SMA team with pulmonologists, dietitian, our therapy team, nurse practitioner who's coordinating this. It's really been tremendous. The procedurists, so Karen Killian and I saw Michaela right there, McAvoy, Alexis Russell, and Nina Natarajan have been fantastic. Our IR staff, the gang with Eric Monroe, who are willing to put a needle in anyone's back and do it incredibly safely. IR, OR, and our ambulatory infusion have been gracious in giving us time and space to provide this treatment. In the third row, our insurance processing specialists have been amazing. Every child who we asked for approval, we received approval. Every child who wanted this drug have received this drug. It has been tremendous. Anesthesia, pharmacy, respiratory therapy, our bioethics group have all been instrumental in providing that care. So thank you. And now we'll open it up to questions.
Thanks for the talk. I enjoyed it. I wanted to ask all of you, actually, as you see Nusinersen and the new AAV coming down the pike and even more coming down in clinical trials, do you see these drugs as being used together in a synergistic way? Do you see one replacing the other? And if you're going to give one IV, you don't have to worry about intrathecal. So this is a very active, moving kind of picture. How do you adjust your systems as these new drugs come down, and how are you going to look at interactions?
It's a great question, Greg. So yes, we are already seeing other clinical trials. We are being asked to participate in clinical trials for sure. So I think that you are right on. I think a combination cocktail approach. So we talked about the systemic approach, getting the gene into the motor neurons. The SMN protein is actually produced in all muscles, in all cells of the body, including the heart, the pancreas, the liver. So there are different approaches that are all being taken right now. There are some approaches that are looking at neuroprotection, other approaches looking at the muscle level, at the neuromuscular junction. And so we continue as a team to focus on providing standard of care, and that is a supportive care. And we are trying we have a registry that we are enrolling all of our families. We're getting consent, IRB approval. We have IRB approval to be able to collect information about these kids and how these kids are doing. We are keeping our ears open to the possibility of participating in other trials. One trial we were just recently asked about was a combination trial. I mean, I think everything now is going to have to be Nusinersen plus. Unless it is on infants, because really all families of older kids have wanted this treatment, with the exception of a small number. And so we are just collaborating with folks from across the country, learning what other people are doing, and doing the best that we can.
Thank you, Sue. My name's Connie. I'm one of the therapists that works with these patients, and it's interesting for us to help families figure out how the changes are going to happen in their kids' lives. And it's been interesting that insurance companies have been willing and thankfully to pay for these. And then I also hear these stories where, for instance, a patient we're working with right now who's 10 and the insurance company won't cover the cost of a wheelchair that elevates. So she can't go to the dining room table and go to the classroom and access her chair and participate in life like we all want to. And the goal of the medicine, obviously, is participation in life and the best life possible. An insurance company pays for some things and not for others. And these are really difficult ethical conversations with family members, and something that we are constantly thinking about.
Thank you. It's a great comment.
I just want to give a quick response to that response, but I want to share, I appreciate that comment very much. I recall maybe 25 years ago having a face-to-face discussion with this one at the University of Arizona Tucson with the state health program, because we were trying to arrange for a child to go home on a ventilator. At this point, they were with portable batteries that were very heavy, and we were trying to come up with which is now is way obsolete, but at the time was a cutting-edge ventilator that was more expensive and was portable, which meant that the child could go outside to the park. And the person's comment was, it's not our responsibility to make sure people can go outside. Our goal is to keep them alive. So it was a bit of a sobering conversation. And I think this is what the challenge we face is that, as you said, there's a bit of de-emphasis of quality of life and what that means versus these very hard medical facts. The challenge is they are trying to provide things fairly for everybody, and the question is, if they provide an elevated wheelchair for one patient, they have to provide it for others. And so part of what they try to struggle with is, how do we deal with this ongoing increase of cost, and how do we prioritize things? And I think that's one of the challenges we have of our current system.
Hi. So I would love to hear, now that we've seen the data, and obviously I know some of these kids too, but we've seen the data on the little babies where the benefit has been potentially the greatest with Nusinersen early on. And I guess the question that I would love to, particularly with Ben, is what about the newly diagnosed SMA infant whose family is not interested in Nusinersen?
Well, sure. Well, I'll say something, but also let's Sue comment about this too, because we have had patients like this. You know, we actually chose not to talk about that because we thought that. Well, no, but no, it's good. It's a great. But the reason why we chose not to, we thought actually in some ways that we wanted to focus on this older patient group because we thought that was actually more challenging. And what I mean by that is that while this is an intervention that can be effective, as you learned, it's not completely effective. There are a lot of burdens associated with it. And so I think the same principle that Sue described before of trying to give people information, engage in decision making, help people make decisions consistent with their values, we still expect to see some patients making different decisions. I think that could change as time goes on, as our interventions become more efficacious and we have more data about that. But for the moment, I think there's still a notion that this is a shared decision-making process, and there's more than one answer that can be made. And I'll let Sue and Mandy comment on this also, because
Yeah, we made, as you probably know, we did face that very question. So we had a family of an infant who was diagnosed at 2 weeks of age because she had an older sibling who had died just about a year earlier, actually. And so we were able to get the family in immediately. And it's actually an important point. And one of the impetus actually for me wanting to present today was we want people to recognize this condition. We want people to let us know immediately that they have any inkling of a concern, because earlier treatment is better. A slide I didn't show was that kids treated immediately after birth are looking to have near normal milestones, at least in the short term. Again, we don't know the long term. So this family opted not to treat, and that was after a long conversation, a couple of conversations actually that I had with them, and they wanted a guarantee. They wanted a guarantee that their infant girl was going to be normal and that she was going to be able to run and jump and play like her big brother. And I wasn't able to give that guarantee. As hard as that was for me at a personal level, I supported them, and we were able to connect them. They lived up north, further north in Seattle, and we were able to connect them to a palliative care hospice program, and she was supported in the community at home with her family. And so I have always tried to be consistent and support families' wishes, and until we truly have that cure, and we're sure of that cure and the data supports that cure, I think I will continue to struggle with it, but I will continue to support those kids and families when they make that decision.
And I'm just going to add with a little bit about our experience with. We have 4 infants who with SMA type 1 who are currently being treated, not as a part of a clinical trial, but just in our clinical program, all who started at less than a year of age. And what I was anxious about needing to be better at my job has certainly borne to be true. 2 of them are doing quite well and have impressive strength gains, and they, correct me if I'm wrong, were ones that were already a little stronger to begin with. And 2 of them are certainly improving, but have proven to be still very time-consuming, very challenging to manage in terms of their breathing, and have still needed BiPAP most of the time, have had tremendous difficulty with secretion management, have been in and out of the hospital. They're with us, and their families are incredibly grateful and incredibly happy. But I will say that there was a time before Nusinersen where the conversation that Sue and I would have usually together with families with the 3 potential paths you could take for support, it was kind of supportive care, loving your child with support from us, high intervention, and then there was this middle path of like, we'll do BiPAP, we'll do cough assist, but it was sort of recognized that path wasn't going to last very long, and that likely we would end up in one direction or the other. And now I feel like I'm more challenged to make that path work, and it takes a lot more work from us and to the family. So I guess to go back to your question, Maida, like, is it, if we know that the struggle could be harder, is that the right thing for a family to have to endure? And does therefore that make it completely acceptable to say, I don't want to undergo this? And I would say yes. So. it's
And
just
on that uplifting note,
Yeah, sorry.
I think it's probably time for us to adjourn for the day, but thank you very much.